When I arrived at Academy Health's 2026 annual research meeting, also known as ARM, I expected to hear a familiar narrative that universal healthcare or single-payer systems are the solution to many of healthcare's biggest challenges. Since moving to the United States from Canada, that is often how I've heard comparisons between health systems in North America framed. ARM challenged me to think differently about comparative healthcare policy. I heard from researchers studying health systems in France, Cyprus, Ghana, Rwanda, Nepal, and many other countries. What stood out to me was that the most interesting comparisons were not necessarily about which country had the best healthcare system. They were about specific policies and challenges, how countries finance care, respond to workforce shortages, expand access, and make difficult decisions with limited resources. That distinction between comparing entire healthcare systems and comparing specific policies changed the way that I thought about learning across countries. Looking at an entire health system can easily become a debate about which model is better. Looking at individual policies allows us to ask more useful questions. What worked? What did not work? What conditions shaped the outcomes that were seen in a specific context? And could some part of that approach be adapted elsewhere? Having lived in different countries, I found that perspective particularly meaningful because I've come to learn that no health system exists outside of its own political, economic, and social context. We may not be able to transplant another country's healthcare system, but we can still learn from how others are approaching problems that many of us share. And this is so interesting because ARM also made me think about what this kind of research means for healthcare administrators like myself. One poster from researchers from the University of Chicago particularly stayed with me because it examined how not-for-profit hospitals in the US use tax-exempt municipal bonds. These bonds give hospitals access to lower-cost financing that can support investments intended to expand their capacity to provide care. The researchers found that after issuing bonds, hospitals increased investment in land, buildings, and equipment, but also increased their financial asset holdings and executive compensation, while community benefit spending did not significantly change. Those gains, moreover, were concentrated almost entirely among hospitals that were already wealthy. What interested me was not simply whether those outcomes were good or bad, it was the management question that research raised. How do healthcare leaders ensure that their financial tools and resources available to their organizations ultimately translate into meaningful values for the communities they serve? As someone beginning my career in healthcare administration, that question has really resonated with me. You see, administrators are constantly making decisions about capital, budget, operations, and organizational priorities. And those decisions may happen far from the bedside, but they ultimately shape what an organization is able to invest in, and more importantly, who it's able to serve and how sustainable that can be. That is also why one of my biggest reflections leaving ARM was that I would love to see more healthcare administrators in the room. Now, healthcare administrators make decisions every day that affect millions, if not of patients across the United States and around the world. And they already attend conferences focused on operations, finance, strategy, technology, and leadership. But those spaces are valuable because they allow us to learn about what other organizations are doing and bring innovative ideas back into our own. But I think ARM offers something different. The conference created an opportunity to engage with research that asks not only what other healthcare organizations are doing or what other health systems are doing, but whether those decisions are actually producing the outcomes we intend. And this is where I had my aha moment. Researchers generate evidence that can challenge assumptions, reveal unintended consequences, and help us understand what works. Administrators are often responsible for translating that evidence into budgets, into strategy, operations, and organizational transformation. Bringing those perspectives closer together can help ensure that research does not stop at identifying problems, but informs the decisions being made within healthcare organizations every day. I came to ARM expecting to learn more about health policy and research, but I left thinking more about the relationship between research and management and about the value of healthcare administrators being part of those conversations. For me, that may have been my most important takeaway. Better health systems require not only good research, but leaders who are willing to engage with that evidence, question their assumptions, and use what they learn to make better decisions, whether within their own context or even considering how decisions they make also trickle down to affect other health systems outside of their context.